Welcome to PFT Tutor with Jeffrey Haynes. Please click the like, subscribe, and notification buttons. It's greatly appreciated. In this video, we're going to review the use of Z-scores to interpret pulmonary function tests and grade the severity of impairment. Traditionally, the percent of predicted has been used to decide if a measured PFT value is normal. According to this method, a value of 80% of predicted or higher is considered normal, and a value less than 80% of predicted is considered abnormal. In other words, the lower limit of normal is 80% of predicted. However, this idea is statistically flawed. A statistically sound lower limit of normal would only misclassify 5% of normal subjects, as depicted by the red dashed line. The percent of FEV1 values from normal females is plotted on the vertical axis against age on the horizontal axis. The statistical lower limit of normal for FEV1 is shown in the black line here. And as you can see, the percentage of normal subjects with a value less than 80% of predicted increases much higher than 5% as people get older. In addition, the statistical lower limit of normal will be different for different PFT values even in the same subject. For example, in this middle-aged subject, the statistical lower limit of normal is 83% of predicted for total lung capacity, 77% of predicted for DLCO, and 55% of predicted for FEF 2575. The statistical lower limit of normal is low for FEF 2575 because that value has a very wide normal range. This strategy to determine the normality of a diagnostic test is unique to pulmonary function testing. Routine blood work, for example, is not graded as a percent of predicted. The measured value is compared to a statistical range derived from normal subjects. The weaknesses of using percent of predicted is not a new concept. In 1979, Sobel and Sobel wrote, "Nowhere else in medicine is such a naive view taken of the limit of normal." Because of the many shortcomings of the percent of predicted, the 2022 European Respiratory Society and American Thoracic Society PFT interpretation standards recommended using Z-scores to establish normal ranges, specifically the 5th and 95th percentile limit, which is a Z-score of minus 1.645 to plus 1.645 of the healthy population, can be used to identify individuals with unusually low or high results. In addition, a 3-level system to assess severity of lung function impairment using Z-scores was also recommended. According to the 2022 ERS ATS standards, there are only 4 categories: normal, mildly, moderate, and severely impaired based on Z-scores. So as you can see in the table, if your Z-score is greater than minus 1.64, you're normal. Mild impairment is a Z-score of minus 1.65 to minus 2.5. Moderately impaired is a Z-score of minus 2.51 to minus 4, and severe impairment is defined as a Z-score less than minus 4.1. Well, that's all well and good, but there may be some of you out there thinking, what the heck is a Z-score? And some of you may have statistics phobia. Well, firstly, let me ease your mind and tell you that Z-scores are really simple, and I'll be able to teach you how to use Z-scores in a matter of minutes. Let's start from the beginning with reference equations. Reference equations, sometimes referred to as predicted sets, are used to determine the expected PFT values in normal subjects. Reference equations are derived from measuring PFTs in non-smoking subjects without apparent respiratory illness. Reference equations allow PFT data collected from patients during clinical testing to be compared to normal subjects with similar determinants of pulmonary function: age, sex, height, and in some cases ethnicity. Age is an obvious determinant of lung function, as there is a period of rapid lung growth during childhood, a plateau during early adulthood, followed by a normal decline in function associated with aging. Born sex is another determinant of lung size. In health, born males will have larger lungs than born females with similar demographics. Height itself doesn't determine lung size, but because there is not an easy and practical way to measure chest dimensions, height is used as a substitute or a proxy. That is, taller patients typically have larger chest dimensions than shorter patients. The role of ethnicity on expected lung size is complex and is currently undergoing scientific re-examination. A predicted PFT value is the average value derived from the normal subjects used to generate the reference equation. If the reference equation data is distributed normally into a bell curve, the average or mean, or some equations use the median, is at the center of the bell curve, shown right here. The predicted value is often referred to as 100% of predicted, which might imply perfect health. However, the predicted or 100% of predicted value is the 50th percentile, just average. For example, if the predicted vital capacity for a patient is 4 liters and the measured value is 4 liters, the patient's vital capacity is average for a normal person with similar demographics. If the patient's measured vital capacity is 4.5 liters, the patient's vital capacity is above average for a normal person with similar demographics. There is no such thing as abnormally high vital capacity, so we don't need to worry about values above the center of the bell curve. They are all normal. However, how should we determine whether values below average are normal? By definition, half of the values collected from normal subjects to generate a reference equation will have values below average. So having values below average is not necessarily abnormal. However, all abnormal spirometry data are below the average value. It is therefore important to be able to distinguish between values below average that are normal and those that are abnormal. The average variance around the center of the bell curve is the standard deviation. Simply stated, one standard deviation is the average distance measured values are from the center of the bell curve. If there is a lot of variability around the mean, the standard deviation will be large and the bell curve will be wide. If there is very little variability around the mean, the standard deviation will be small and the bell curve will be narrow. For example, here are 2 bell curves of blood gas QC measurements from 2 analyzers. Both analyzers report a mean PO2 of 61 millimeters of mercury, as shown here in the center of the bell curve. However, analyzer A has less variability around the mean, a standard deviation of 1.3 millimeters of mercury, whereas analyzer B has more variability around the mean, a standard deviation of 2 millimeters of mercury. Because analyzer B has more variability, the bell curve is wider than the bell curve of the data from analyzer A. Similarly, some PFT values collected to generate reference equations will have more variance than others, which mean there will be larger or smaller normal ranges for different values, for example, FBC versus FEF 2575. In addition, normal ranges may also be wider in older subjects. Once the mean and standard deviation are determined, the normal range around the center of the bell curve can be determined using the empirical rule. The empirical rule states that under normal conditions, 68% of repeated measurements should fall within 1 standard deviation of the center of the bell curve, 95% of repeated measurements should fall within 2 standard deviations of the center of the bell curve, and 99.7% of all repeated measurements should fall within 3 standard deviations from the center of the bell curve. For example, let's say you perform 20 blood gas controls on a calibrated blood gas analyzer. The average PO2 from the 20 measurements is 90 millimeters of mercury with a standard deviation of 1 millimeter of mercury. The 3 standard deviation range for this set of data is therefore 90 plus or minus 3 millimeters of mercury, or 87 to 93 millimeters of mercury. Therefore, if the blood gas analyzer continues to function properly, according to the empirical rule, you can expect that 99.7% of any additional QC measurements will report a PO2 between 87 and 93 millimeters of mercury. A QC result above or below the 3 standard deviation range is unusual if the blood gas analyzer is functioning properly. A QC value outside of the 3 standard deviation range would therefore raise suspicion that the blood gas analyzer is not functioning properly and troubleshooting should be performed. Blood gas QC and PFT biological control data are usually plotted in a Levy-Jennings chart. As shown here, slow vital capacity data is plotted over time. The mean value is depicted by the solid line, while the plus or minus 3 standard deviation range are depicted by the dashed lines. If the spirometer is functioning properly, all slow vital capacity measurements should fall between the 3 SD range. If they're outside of that range, then you should suspect that something is not functioning well and do troubleshooting. So when we look at a Levy-Jennings chart, the way to kind of conceptualize this is to think of that bell curve as basically turned on its side, as shown by the blue bell curve here. A z-score is simply the number of standard deviation a measured value is from the center of the bell curve. Therefore, the center of the bell curve, the mean or predicted or median, has a z-score of 0, as shown here. If a recorded forced vital capacity, for example, is 1 standard deviation below the center of the bell curve, the z-score would be -1. If a recorded forced vital capacity is 1 standard deviation above the center of the bell curve, the z-score would be +1. A bell curve has 2 ends or tails. A two-tailed bell curve is important if a value can be both abnormally high or abnormally low. Thinking back to the blood gas PO2 QC example, a QC result could be either abnormally low, greater than 3 standard deviations below the mean, or it could be abnormally high, greater than 3 standard deviations above the mean. When a plus or minus 2 standard deviation range is used as the normal range, there is a 5% error, or 2.5% on each end of the bell curve. There is a 5% error because the empirical rule states that under normal conditions, 95% of repeated measurements will fall between 2 standard deviations of the mean. So you would have 2.5% error on one side, 95% in the middle, and 2.5% error on the low end. The error means that 5% of normal values may fall outside of that plus or minus 2 standard deviation range. As I said, 2.5% at the high end and 2.5% at the low end of the bell curve. For spirometry measurements like forced vital capacity and FEV1, the recorded values can only be abnormally low. They cannot be abnormally high. Because there cannot be an abnormally high spirometry value, the entire 5% error can be located at the low end of the bell curve. This becomes a one-tailed approach. For PFT interpretation, a z-score of -1.645 is used as the lower limit of normal because the empirical rule states that under normal conditions, 90% of recorded values should fall between plus or minus 1.645 standard deviations or z-scores from the center of the bell curve. Using -1.645 standard deviations from the mean or z-scores as the normal range places the 5% error at the low end of the bell curve as shown here. This means that a PFT value with a z-score lower than -1.64 as shown here in the yellow and in the red can only be expected to be recorded in 5% or 1 in 20 patient with normal lungs. So if a PFT value has a z-score below -1.645, this is an unusual finding in a patient with normal lungs, and the post-test probability of lung disease goes up. So you would expect or suspect that this patient could have a problem. Now, there are some PFT values such as DLCO, TLC, and residual volume that can be both abnormally low and abnormally high, which might justify using a two-tailed approach, for example, plus or minus 2 standard deviations or plus or minus 2 z-scores. However, for uniformity and simplicity, a z-score of plus or minus 1.645 is used as normal range for all PFT values. Okay, so let's practice. I'm going to show you examples of PFT data with no predicteds, no percent predicteds, no flow volume loops, just a recorded value and the z-score, and you'll see how easy using z-scores really is. So here's our first example. So we have a forced vital capacity of 3.5 liters. The z-score is 0.51, so that would be located right about here. The FEV1, you have a raw value of 3 liters. The z-score is 0.98, so almost at 1, so right about here. And the ratio of FEV1 to FVC is a ratio of 0.86, which is a z-score of 0.92, which is also right around 1. So the interpretation is easy. This is normal. The z-scores for forced vital capacity, FEV1 and FEV1 to FVC are all higher than the lower limit of normal of minus 1.64. In our next example, we have a recorded forced vital capacity of 3.25 liters. The z-score is 0.04, so very close to 0, and 0 z-score is at the center of the bell curve, or the mean or the predicted value. The FEV1 is 1.55 liters. The z-score is minus 2.29, so it's way over here, below the lower limit of normal. And the ratio of FEV1 to FVC is 0.48, with a z-score of minus 3.59, so that's way over here. So the interpretation, there is obstruction. The FVC is normal with a z-score close to 0, but the FEV1 and FEV1 to FVC ratio are abnormally low, both with z-scores below the lower limit of normal of minus 1.64. We can also use the z-scores to assess the severity of these defects. So the FEV1 has a z-score of minus 2.29, so that would be mildly impaired. But the FEV1 to FVC ratio has a z-score of minus 3.59, so that would be moderate severity. In this example, we have a forced vital capacity of 1.82 liters with a z-score of minus 2.76, so that would be located here on the bell curve. The FEV1 is 1.41 liters, a similar z-score of minus 2.69, so again, located in this area of the bell curve. The ratio of FEV1 to FVC is 0.78, and that has a z-score of minus 0.43, so that's going to be located right over here, so this is clearly in the normal range. So the interpretation is restriction. Both the FVC and the FEV1 are abnormally low, with z-scores below minus 1.64. There is no obstruction because the ratio of FEV1 to FVC is well above the lower limit of normal. In terms of severity, the FVC with a z-score of minus 2.76 and the FEV1 with a z-score of minus 2.69 would be classified as moderately impaired. So the z-scores, as I said, can be used for any PFT variable, so let's look at DLCO. In this example, the measured DLCO is 25.21 mLs per minute per millimeter of mercury. It has a z-score of 0.04. So that's going to be right here at the center of the bell curve. This would be called the average or the predicted value. So this is easy. It is normal because the z-score is close to 0. Next, we have a recorded DLCO of 17.01 mLs per minute per millimeter of mercury. The z-score is minus 1.37, so that's going to be located in this area right here. So the interpretation is this is normal. The z-score is higher than minus 1.64, but below positive 1.64. As I mentioned earlier, DLCO is a number that could be both abnormally low or abnormally high. Next, we have a recorded DLCO of 12.89 mLs per minute per millimeter of mercury. The z-score is minus 2.92, that's close to minus 3, way over here. So this is abnormally low. The z-score is below our lower limit of normal of minus 1.64. And based on the z-score of minus 2.92, this would be classified as moderately impaired. In this example, we have a DLCO of 26.65 mLs per minute per millimeter of mercury. The z-score is plus 1.73. So this is above our upper limit of normal of plus 1.64 right here. So this would be interpreted as abnormally high DLCO because the z-score is above plus 1.64. Now, this can certainly happen, but you don't see this as frequently in a clinical PFT lab as a low DLCO. The causes of an increased DLCO include obesity, but that doesn't happen in all obese patients. You can see it in asthma, you can see it in polycythemia, or anything that increases cardiac output. So let's look at some lung volume data. So in this lung volume table, you can see we're measuring the total lung capacity, the vital capacity, the functional residual capacity, the residual volume, and the residual volume to TLC. You can see that in all of these examples, all of the z-scores are really close to zero. A little bit above, a little bit below, but we're all around zero. So all of these would be considered average or near the predicted value. So these would be a normal panel of lung volumes. In this set of data, we have a TLC of 5.45 liters. The z-score is plus 2.93. So that's going to be over here on the bell curve. The FRC of 4.36 also has a very high z-score, plus 4.5. It's off the scale. Same thing applies to the residual volume, a very high z-score of 4.3, once again off the scale. And the RV to TLC ratio of 0.62 is also high with a z-score higher than 4. All of them are off the scale over here. The only thing that's low is the vital capacity of 2.06. It has a z-score of minus 1.80, so that's going to be over here, below the lower limit of normal of minus 1.64. So the interpretation is you have hyperinflation because the z-score for the TLC is high. There is air trapping because the RV to TLCO ratio also has a z-score above the upper limit of normal of 1.64. All of the different values like FRC, residual volume are also increased. The vital capacity is abnormally low with a z-score below minus 1.64. They don't really offer severity grades for things above the upper limit of normal, but in terms of the forced vital or the vital capacity, a z-score of minus 1.8 would be classified as mild impairment. In our last example, we have a TLC of 3.37 liters, which has a z-score of minus 4.59. So that's way over here. The vital capacity is 2.08 with a z-score of minus 5.05. So once again, way over here. The FRC is 1.96 liters with a z-score of minus 2.8. So that would be in this region of the bell curve. The RV is 1.29 with a z-score of minus 1.91, so just below 2. And the RV to TLC ratio of 0.38 is 1.25, so that would be considered a normal value. So the interpretation on this example is restriction. The TLC, the FRC, and the RV z-scores are lower than minus 1.64. There is no air trapping because the RV to TLCO z-score is below positive 1.64, and the vital capacity is abnormally low with a z-score below minus 1.64. In terms of severity, the worst values are the TLC and the vital capacity, which z-scores are lower than minus 4.1, so those would be severe impairment. The FRC at 2.8 would be classified as moderately impaired. The residual volume with a z-score of minus 1.91 would be mildly impaired. And as I said, the RV to TLC ratio is normal. The 2022 ERS ATS PFT interpretation technical standards recommend that z-scores be used to grade PFT results. The use of 80% of predicted as a lower limit of normal for PFT data is statistically invalid and should be abandoned. Z-scores are superior to percent predicted because they are statistically sound, and using a plus or minus 1.64 z-score as the normal range is applicable to all PFT values regardless of the width of the normal range. In addition, the use of z-scores to determine the normal range of PFT values is independent of the patient's age, sex, height, or ethnicity. I know that this has been an area of confusion for many people, so I hope that you found this very useful and now feel comfortable using z-scores to interpret PFT data.
Thank you for watching PFT Tutor with Jeffrey Haynes. Please click the like, subscribe, and notification buttons, and we'll see you next time.